Thank you very much for inviting me and giving me the opportunity to give you this talk today. It's quite a broad remit, this topic, and I could talk for a long time about it. So I'm going to be quite brief, and I'll skip through some of the slides quite quickly. The slides will all be available for you following on from today. What I thought I would try and concentrate on is updating things that are changing, and the screening program is changing. It's in flux at the moment. It's being updated. We're moving towards HPV, and it can be quite bewildering, even for us who run colposcopy services, have clinics every week. The changes are happening, and I thought I'd just try and outline where we are and where things are moving towards. So this talk has to include a brief outline of the vaccination program, which was introduced in 2008. I want to talk a bit about what's being rolled out at the moment, which is the HPV triage and the HPV test of cure. That's currently underway. Primary HPV testing, which is an alternative approach, which is looking more and more like the future of HPV and cervical screening, and a bit about the rationale and cost implications. So as you all know, there's now a very, very clear evidence-based, well-established etiological role of HPV in the development of cervical cancer, and also, in fact, several other types of cancer. In 2001, the Sentinel site program was rolled out. There were 6 Sentinel sites, and HPV triage was introduced to the cervical screening program initially at these sites. And the rollout of the program now is based on the experience of the Sentinel site program. So the recommendation came in 2010, and it's just in the process of being implemented locally at the moment. So HPV, as we all know, it's very common. In fact, most women will be infected at some point during their lifetime. The progression from HPV infection to cancer is less clearly understood, although the link is very clear. And what we know is that the majority of women who are infected with HPV, actually their immune system clears this very quickly, and the infection is transient. And in a smaller subset of women who are infected with the higher risk subtypes, in particular 16 and 18, we know that there's some malfunction that leads on to persistent infection, and in the longer term, a higher risk of CIN and development of cervical cancer. I'm sure you know this, but almost 100%, well over 99% of cervical cancers contain HPV DNA. And conversely, women who have not got HPV infection are extremely unlikely to develop cervical cancer. And this specificity on one hand and sensitivity on the other hand forms the rationale for introducing the HPV screening program. So this was first rolled out in Australia in 2007, so they've got the relative longest term experience with this, just by a short margin. And in September 2008, this was starting to be introduced nationally in the UK. So projecting forwards, it's going to take many decades because we're vaccinating women very young, 12 and 13 years old. So these cancers that affect women later in life, we're clearly not going to see the outcomes till much later on. But there has been some projection, and in fact, in women less than 30 years old, we're expecting a 60% reduction as a direct result of the NHS vaccination program. The vaccination targets only the highest risk subtypes, so 16 and 18. We know they're responsible for 70% of conversions to cervical cancer, but clearly that leaves 30% that they're not vaccinated against. And so women who are vaccinated are going to have to remain, for the time being, within the cervical screening program. The future may change that, but that's how things are looking at the moment. So, as I said, where we are at the moment is HPV triage and HPV test of cure. So I'm just going to talk a little bit about what triaging means. And this only applies to women who are on normal recall. So triage isn't for women who have been treated or women who are on more frequent recall, having been seen at colposcopy service in the past. This is women who are on normal routine recall, who have cytology, so their smear test, which is looked at down the microscope, shows a low grade, so a borderline or mildly dyskaryotic smear result. These ones then go on and have HPV testing. In women with low grade smear abnormalities, those who are HPV positive, we know 15 to 20% of these are going to have an abnormality, so CIN, of a higher grade that's going to require treatment. So these women with a mild abnormality and HPV positive do require immediate referral to the colposcopy service. Conversely, women with HPV negative, even with a mildly dyskaryotic smear on cytology, are extremely unlikely, and the current recommendation is that those women don't need to go to colposcopy, they return to normal recall. So obviously in primary care, you're going to see the knock-on effect of this as being able to reassure women much earlier in their pathway of presentation. So the other arm, the test of cure with the HPV testing, this is women who receive treatment, so LETs or less commonly ablative treatment or cone biopsy for any grade of treatment, any grade of CIN. And this looks at the 6-month recall at the risk of recurrent disease or disease that's likely to progress and require further treatment. So again, if HPV is negative, they immediately return at that point, regardless of the grade of CIN, to 3-yearly recall. So that's a huge difference to the 10 years of annual recall that we've been experiencing up to now. Clearly, if it's HPV positive at that stage, then we're going to follow them up more closely in the colposcopy service. So approximately 80% of women that are going to be treated for CIN are therefore going to avoid having annual screening. Glandular abnormalities is something completely different that's not included in any of the HPV screening program. Primary testing is something quite different, and this is likely to be quite a radical change from the way that the screening program works. This is where we look at HPV without doing any cytology at all. So we use this as it describes as the primary test, and we only perform cytology in those women who are HPV positive. There's been a lot of work that has shown this is going to be the way forward. It provides a higher sensitivity for pickup of CIN and those that are likely to progress to cervical cancer. And there was quite a large study, well, very large, RCT, which was published in Italy in 2010, which had 2 arms, 81,000 women in total, and it showed a higher sensitivity. It found that in younger women, there is a higher false positive rate. So there is the trade-off of a slight reduction in specificity, but of course that's going to be picked up by the cytology and the colposcopy service. What it did find in the second round of testing was that there was a much, much better pickup of cervical cancer. So there were 9 who were picked up in the initial cytology group, which had been randomized against the initial HPV group, in which all of them were picked up in the first round of testing. So this is how the HPV program, where we are at the moment, how this is affecting. And as I say, I'm not going to tell you everything about the program. I wanted to focus on how this is going to affect you in primary care. So the current recommendation, which is quite a large change from what's been happening until very recently, is that with biopsy-proven CIN1, they should have a smear test, a cytology, at 12 months. So we no longer need to follow up women at 6 months in the colposcopy service, perform colposcopy, or at 12 months. The cytology is enough. If they're borderline, then we repeat the HPV. Women under 25, as we know, are currently not included in the screening program, and because of this increased false positive rate with HPV that I described, this also applies to the HPV screening, and they're not eligible, in fact, for NHS funding for HPV triage. In terms of test of cure, if the woman doesn't turn up following treatment and comes back to you in primary care, she should still be included in the HPV test of cure protocol. You just need to outline that on the smear form when it's sent in. So there are huge cost implications. I think the largest cost implication is this test of cure and discharging people back to routine recall, so 3 yearly recall after the 6-month follow-up. And that's projected to provide a potential saving to the NHS of £15 million per annum. In terms of repeated testing in women with low-grade abnormalities who have HPV screening, there's a projected 6 million annual improvement. So implications for yourselves, ultimately there are going to be fewer women, both through the vaccination programme and the alterations to the screening programme. There's going to be, over the next few decades, there's going to be a vast decrease in the number of women in this country with cervical cancer. Those that do have cervical cancer are going to be picked up earlier, making prognosis and counselling a lot more straightforward. And there's been quite a lot in the media about the role of the GP in the HPV screening programme, and it's widely felt that the main benefit is going to be your interaction with the patients and your ability to counsel the patients regarding the results and reassure them at a much earlier stage than we're able to do. Initially, the Sentinel site study did show a spike in referrals to colposcopy with the increased levels of pickup. This activity is likely to decline though due to this reduction in number of follow-up visits over time. There was a fear that there would be a large peak of women coming to their GPs, what's HPV, you know, I've got cancer, but in fact the data and reports from the Sentinel site study have not reflected that. There wasn't a large influx of more worried women in light of this programme. Thank you very much.